I have a stone clinic every Monday afternoon. I really, really love my stone clinic because I can do quite a bit to help people. It's always very gratifying for me to hear somebody come back and say, I was getting stones once or twice a month, and now it's been 8 or 9 months and I haven't gotten a stone. My clinic is all just applied physiology. And of course, since this is what I love, this makes it even more fun. So today's lecture, actually, I'm going to talk about stones as a manifestation of systemic disease. So this is not going to be a review of all types of stones, etc. This is going to be people that I saw in clinic that I was then able to diagnose as systemic disease, based on the fact that they presented with stones. Please feel free to stop me at any time or ask any questions. Here are my disclosures. So today we'll be talking about systemic diseases that have stones as a part of their manifestations and review some very common presentations of stones. So our first case is a 51-year-old woman who was referred for hypokalemia, metabolic acidosis, chronic kidney disease, and stones. She had passed many stones but had never had a stone analyzed. She had had a very sad history and had multiple episodes of trauma, had chronic low blood pressure. Her physical exam was remarkable in that her blood pressure was relatively low, and she looked chronically ill, probably about 10 to 15 years older than her stated age, and just absolutely awful dentition. Almost all of her teeth were broken off. CT of the abdomen showed small obstructing stones bilaterally, and here is her lab work. So you'll see that I have carefully placed stars at the spots for you to look at. And obviously the abnormal things on her bicarb was only 10. Her creatinine was somewhat elevated at 1. Alkaline phosphatase was very high. Her liver functions were high. And you'll notice that her urine pH, despite the fact that her serum bicarbonate was 10, her urine pH was 7. And here are her urine electrolytes: urine sodium 46, potassium 45, chloride 53, and this gives her a calculated anion gap, urine anion gap of 50. Her urine and serum osmolality were about the same at 290. So some additional lab work here shows that, again, she has more evidence of liver abnormalities. GGT was somewhat elevated. Magnesium and phosphorus were okay. Aldosterone was a bit on the high side, probably consistent with her low blood pressure. And her 24-hour urine was remarkable in that her 24-hour urine calcium was really not very high, 108 milligrams in 24 hours. For a woman, anywhere up to 200 to 250 milligrams is considered acceptable, and for a man, about 250 to 300 milligrams. Her urine citrate, however, was quite low at 265. So citrate is obviously a normal metabolic component. It is utilized in the proximal tubule, particularly when somebody has metabolic acidosis. Proximal tubule cells just chew it up, and so you end up having less in the urine. Citrate is a natural inhibitor of stone formation because it will chelate the calcium that is in the urine. So when people have a low citrate, this is a high risk factor for calcium stone formation. And hers is quite low. This is also consistent with her significant metabolic acidosis, however. Okay, so at this point, what do we have? We have somebody who's got stone disease. We don't know the type. She's got evidence of distal renal tubular acidosis. She's got a metabolic acidosis with a normal anion gap. Her urinary anion gap is positive. Does everybody in this room understand why you calculate a urinary anion gap?
No.
Okay. All right. So you calculate a urinary anion gap as a way of indirectly measuring how much ammonia is in the urine. Remember that distal trapping of ammonia is a mechanism for the distal tubule to secrete hydrogen ion and get rid of your net acid in a day. However, as you know, if you send down urine electrolytes, a urine ammonium never comes back. Hardly anybody measures that. So to get a sense of how much ammonia is in the urine, you calculate the anion gap. For all of us sitting in this room, unless one of you is actually secretly a rabbit and you eat nothing but lettuce, and so you have to get rid of bicarb every day instead of acid every day, all of us have an acid urine, and our urinary anion gap is negative because we have sodium chloride, potassium chloride, and ammonium chloride in our urine. If you don't measure the ammonium, then your sodium plus your potassium minus your chloride is going to be a negative figure. So all of us have a negative urinary anion gap. And certainly somebody who has a metabolic acidosis of the degree that she had with a bicarb of 10, you should have a negative anion gap because your kidney should be pumping out a ton of ammonia in order to get rid of that net acid. So that is how we can make the diagnosis of distal renal tubular acidosis, because she has no ammonia in her urine. She's isosthenuric, meaning that the osmolality of her urine is the same as her serum. It's just about midline there. She's got some abnormal liver tests. Okay, so her protein electrophoresis showed no M spike. She did have a positive ANA, at which point, after she was coming back to the clinic and we were going over all this lab work, she just then volunteered, by the way, my mouth is very dry and so are my eyes. Her complements, anticardiolipin, were negative. She was sent to ophthalmology where Sicca syndrome was confirmed, and she was sent to rheumatology, at which point they thought that they agreed with the diagnosis that I had given her by this point, but thought no immunotherapy was needed. She did parenthetically go to GI, had a liver biopsy done, and had macronodular cirrhosis. So this woman had Sjogren syndrome. So Sjogren syndrome is a form of classic tubulointerstitial kidney disease. A fair percentage of people, about 25% of people with Sjogren syndrome, will get some kidney disease, and the vast majority of the time it is tubulointerstitial. These guys don't develop nephrotic range proteinuria or glomerulonephritis. These guys have an interstitial process that eventually will destroy the kidney. So she presents with many of the features that you would see with a classic tubulointerstitial kidney disease. Little proteinuria, renal tubular acidosis, nephrogenic diabetes insipidus, hypokalemia, and a low blood pressure, because these guys frequently will waste sodium as opposed to the glomerular diseases where you see people hanging on to sodium so much. There's, quite frankly, almost no literature whatsoever on Sjogren syndrome and stone disease. In her case, her risk factors for stones were her distal RTA and her hypocitraturia. And if you see somebody who has stones and has distal RTA and a low urine citrate, then your differential diagnosis is going to be either idiopathic distal RTA, an entity that's called medullary sponge kidney, and I have a picture of that, or the use of carbonic anhydrase inhibitors. So most of us don't see the people with glaucoma that are on a carbonic anhydrase inhibitor that much. However, we do see a fair number of people who are on topiramate, which also has carbonic anhydrase inhibitor activity and can result in stones as well. And the treatment is either oral bicarbonate or citrate, symptomatic relief for the eyes and mouth. Eyes and mouth. And this woman is also being evaluated potentially for a liver transplant. Her creatinine has stabilized between 1.3 and 1.7. So, picture of one of her stones. And then here is medullary sponge kidney seen on an intravenous pyelogram. So here is the collecting system here with the calyces, and you'll notice these little fluffy halos out here. These are areas where you have basically enlargement of the distal tubules at that site, and so the contrast material accumulates there, and that is absolutely classic for medullary sponge kidney. If you're ever looking for medullary sponge kidney, you think that might be the case, and you send somebody down either for an intravenous pyelogram or a CT with contrast, you absolutely have to tell the radiologist this is what I'm looking for, medullary sponge kidney. Otherwise, they won't look for it. And they do have to find these great pictures of these halos. Okay, case 2 is a 54-year-old African-American man who was referred for nephrolithiasis and CKD. He'd actually presented in a very dramatic fashion with AKI that was dialysis dependent and bilateral absolutely huge stones that were obstructing on both sides, for which he underwent surgery. He had no history of renal disease, no prior history of stones. He didn't have fractures, dyspnea, fever, vitamin D ingestion. His physical exam was completely normal. If you saw this guy, you would never guess in a million years that he had anything going on at all. CT of his abdomen showed bilateral obstructing stones after his surgery. These were, of course, missing. And here's his lab work. So this guy, again, he has some degree of metabolic acidosis. However, this is certainly warranted in him because his creatinine was 4.7. Notice his calcium, 12.2 milligrams per deciliter, clearly quite high. And although his albumin is normal, that's still a very high calcium. His parathyroid hormone was 9. Hopefully everybody in this room realized that that's quite low. So that he had a low parathyroid hormone level. His 25-hydroxy vitamin D was 11. His serum calcium was 7.1, phos 3.1. He had 2 measurements of 125 dihydroxy vitamin D3. One was 88 and the other was 149 picograms per ml. His rest of his workup was almost completely negative. On his 24-hour urine, you'll notice that his 24-hour urine calcium was highish, but not hugely high. Citrate was quite low at 265. When you see somebody who has kidney failure, almost all people with kidney failure will have a low urine calcium, frequently less than 100. So to see 234 in the face of a serum calcium of 4.7 is really quite significant. So this guy had hypercalcemia. He had a suppressed PTH and a very, very elevated active vitamin D level. So is this due to either excess production of vitamin D, or is this due to inadequate inactivation of vitamin D? Because both of those scenarios can occur. He also had calcium oxalate nephrolithiasis as well. And at his follow-up appointment after we had all this lab work, and I asked him about a few things, all of a sudden he comes out and his wife says, "Oh, but your brother has sarcoidosis." So, got a high-resolution CT on him. He had mediastinal adenopathy, had a biopsy that showed non-caseated granulomas. He was treated with high-dose steroids. His calcium came down. His 125 came down. His 24-hour urine calcium came down. His creatinine has stabilized at around 2, and he is currently off steroids and stone-free. So, nephrolithiasis as a presenting symptom for sarcoidosis is very, very uncommon. But it's more frequently seen in African Americans, and you can see asymptomatic nephrolithiasis in another small percentage, and nephrocalcinosis in about 5%. Like Sjogren syndrome, renal involvement with sarcoidosis is interstitial. This is not generally a glomerular complication. You can see hypercalciuria in about 50% of the people with sarcoidosis and hypercalcemia in 10 to 20%. So the mechanism of the hypercalcemia and the hypercalciuria, of course, is the fact that the macrophages within the granulomas are activated and will produce large amounts of 125 dihydroxy vitamin D3. Now, all of us sitting here also have macrophages that are perfectly capable of making active vitamin D3. However, the amounts that are made are teeny, and they have an autocrine or a paracrine type of function, not an endocrine function. Under normal circumstances, the only 2 organs which make enough vitamin D to have an endocrine function are the kidney and the placenta. That's it. However, when you get granulomatous disease, you get enough vitamin D made that it circulates. So, he had the classic sarcoid picture, which is basically hypercalcemia, a suppressed PTH, a low or a normal 25-hydroxy, and a high 125 vitamin D. His risk factors for stones, obviously, were the hypercalciuria. And if you see this situation, your differential diagnosis is going to be vitamin D intoxication, meaning somebody who just takes a boatload of vitamin D, lymphoma, other granulomatous diseases, and there are some rare individuals who have a mutation in the inactivating enzyme for vitamin D that can get this as well. So here is calcium oxalate stones. Kind of look like some of those little mines that you see in the World War II movies. Case 3. This is a 52-year-old Caucasian woman who was referred for stone evaluation and chronic kidney disease following a nephrectomy. She had a history of schizophrenia. She'd had a staghorn calculus surgery complicated by a nephrectomy 5 years previously. So she had a single kidney, and then she'd been lost to follow-up. Her examination was notable only for anxiety, restlessness, and she had multiple tardive dyskinesias. CT of the abdomen showed 2 non-obstructing stones in the left kidney. Obviously, the right kidney was absent. And here is her lab work. And you'll notice that the features that are abnormal here, she's got a fairly high calcium, 11.4, with a normal, not a high albumin. Her alkaline phosphatase was relatively high as well. Her PTH level ranged from 60 to 73 picograms per ml. Her 25-hydroxy vitamin D was, if anything, on the low side. Her calcium was, her ionized calcium, was 6 milligrams per deciliter, or 1.5 milliequivalents per liter, remembering that the upper limits of normal for an ionized calcium is, depending upon which lab you're in, is usually like 1.1 to 1.2. Her 125 level was variable, and you can see that she was on a thiazide diuretic for hypertension, and even on a thiazide diuretic, her 24-hour urine calcium was 237. So this woman has hypercalcemia, a high PTH, an intermittently elevated 125 vitamin D, calcium nephrolithiasis, and osteoporosis. And the answer is, this woman has primary hyperparathyroidism. She's got a high calcium with a non-suppressed PTH level. Her bone density also showed osteoporosis, and her parathyroid scan then was notable for a focus activity in the mid-left thyroid area. She went for parathyroidectomy here, had the nodule removed. She's currently on therapy for osteoporosis. Her calcium is completely and totally normal at this point, and she's had no more stones. So stones are actually a classic presentation for hyperparathyroidism. You see there's stones, bones, blah, blah, blah. However, interestingly enough, only 15 to 20% of patients who are hyperparathyroid will have stones. We are diagnosing now hyperparathyroidism much, much more commonly and much earlier than we used to, because everybody gets a BMP or a Chem7 or whatever, and calcium comes back on it. So we're diagnosing all these people that have very, very mild degrees of hyperparathyroidism and probably will never get stones. So the statistic I read was that 5% of stone patients have hyperparathyroidism, and maybe my own practice is a little skewed, but I would say that I easily diagnose 5 or 6 cases of primary hyperparathyroidism per year. You know, and I'm not an endocrinologist. I'm just diagnosing them on the basis of looking at their stone disease. One other interesting aspect of hyperparathyroidism that has come to light more recently is that there are a group of individuals who have hyperparathyroidism who have a normal calcium. And whether or not this represents simply an early stage of hyperparathyroidism or not is unclear. But these individuals who have normal serum calcium, high PTH, will often have, or almost always have, hypercalciuria, so too much calcium in the urine. The most common stones that you see with hyperparathyroidism are calcium oxalate stones, just like the last case, but you can also see calcium phosphate stones as well. Again, these are commonly associated with a low bone density because of the effects of PTH on bone, and neuropsychiatric manifestations are also very, very common. So with hyperparathyroidism, your risk factors for stone formation are hypercalciuria and a relatively alkaline urine. Remember that both types of calcium stones, calcium oxalate and calcium phosphate, both will have a greater chance of forming in an alkaline urine as opposed to the uric acid stones, which have a greater chance of forming in the acid urine. And sometimes people with hyperparathyroidism also have hypocitraturia because of alterations in acid-base metabolism in the proximal tubule. Now, if you see somebody whose PTH is high, then you have to think about, is this primary or secondary hyperparathyroidism, or is this familial hypocalciuric hypercalcemia? Because even those individuals with FHH also will frequently have either an upper limit of normal or even slightly high PTH. And by the way, this is like one of those things that they love to ask you on the board exam, is about hypercalcemia and FHH. So if you see that, remember that with secondary hyperparathyroidism, the PTH level will be high, the calcium will be normal or low, and you also need to look at the vitamin D level. So if the 25-hydroxy is low, they're actually vitamin D deficient. That may also produce secondary hyperparathyroidism. If the individual has a very low urine calcium, let's knock out the renal failure patients. We already talked about how that would complicate the issue. But if they have normal kidney function, they have a relatively high PTH, they have a high calcium, and their 24-hour urine calcium is less than 100, then you're probably dealing with familial hypocalciuric hypercalcemia. So why is that even important to distinguish? Well, first of all, FHH is completely benign. This doesn't cause anything. This doesn't produce stones, it doesn't produce bone disease or anything like that. So you don't want to be going out, whipping out somebody's parathyroid gland if they have FHH. You do that, and you are then leaving them wide open to a lifetime of taking high doses of vitamin D and calcium. So remember the FHH. Nice picture of a calcium phosphate stone. Okay, so here is a 57-year-old Caucasian man who was referred for recurrent calcium oxalate nephrolithiasis. He's got a family history of hypertension and hyperlipidemia, a positive family history of osteoporosis. Physical exam was completely unremarkable. CT of the abdomen showed bilateral, non-obstructing calcium stones, and his bone density showed osteopenia. So what does this guy have? So here's his lab work. I think we would all agree it's pretty boring. There's nothing really going on there. The rest of his lab work, PTH levels kind of all over the place. Phosphorus kind of maybe on the lower limits of normal, hard to say. If you look at his 24-hour urine sample, though, you'll notice that he has substantial hypercalciuria. 24-hour urine calcium of 325 milligrams. You know, remembering that for a man, anything over 250 to 300 is considered hypercalciuric. Now, hypercalciuria is a continuous variable. So the person who puts out 100 milligrams of calcium in the urine is at a lesser risk for forming calcium stones than the guy who puts out 175, and they're at a lesser risk than the person that puts out 250, et cetera, et cetera. So there's a continuum of risk. The reason that we choose the levels of 200 and 250 for females and males respectively is hypercalciuria. It's because at those levels, then your risk of stone formation really does go up more dramatically. What's the most calcium I've seen, in a 24-hour urine specimen? 800 milligrams. And yes, this person has terrible stone disease. So it is definitely a continuum. But that's the biggest thing on this, guys, is that his calcium is a little bit high. You'll notice his uric acid is a little bit on the high side. The 24-hour urine sodium, I have it down there as high, but let me just say this is par for the course. Most people don't get down to their 2-gram sodium diet, which is about less than 100 milligrams. So this guy has hypercalciuria with a normal PTH and a normal 125, and he's got nephrolithiasis, calcium nephrolithiasis, and osteopenia. So this guy has what maybe 60 to 70% of the stone patients that I see have. This guy's got idiopathic hypercalciuria. And it's called idiopathic hypercalciuria because we don't know what causes it. It is the most common cause of hypercalciuric stone disease. And these people have a relatively high gut absorption of calcium, higher than a non-hypercalciuric patient. However, it is not high enough to offset the hypercalciuria. So they may be absorbing 300 milligrams in a day, but they're putting out 450. All right, the important thing, again, both for your taking care of patients who may have this, as well as for your board exam, is that if you diagnose somebody with idiopathic hypercalciuria, the treatment of choice is a thiazide diuretic, and it is not to put this person on a low calcium diet. These people have a fixed renal loss of calcium. So if you put them on a low calcium diet, they're going to continue to waste calcium even if they don't take in enough, and then they will end up with even more osteopenia. So a certain percentage of these individuals, you see low bone density with the stones and the hypercalciuria, but this is not a constant feature. And the degree of bone loss does not correlate with stone formation at all. So you can't say, oh, you've got bone loss, so you must be more prone to getting stones. Interestingly, there are probably, idiopathic hypercalciuria is a syndrome. This is not a disease. And there are probably hundreds of different causes of idiopathic hypercalciuria. We do know that in some cases there are polymorphisms in the vitamin D receptor and alterations in the expression of the vitamin D receptor that seem to increase calcium reabsorption. These individuals, almost all of them, show excessive postprandial renal solute excretion. Interestingly, so you take 10 stone formers, idiopathic hypercalciuric stone formers, and 10 normals. You give them exactly the same meal with exactly the same solute content, and then you measure their 24-hour urine in the next 2 to 4 hours, and those guys that are the idiopathic hypercalciurics will have more sodium, calcium, and other solutes in their urine. So there's clearly, something with calcium handling, solute handling in the kidney that gives these guys their hypercalciuria. There's also a fairly strong association with metabolic syndrome, and there have been many studies now to show that individuals who have idiopathic hypercalciuria are also at a higher risk for cardiovascular disease as well. So the treatment of choice here is thiazide diuretics, a low sodium, low purine diet, and obviously the high urine volume, which is the same for everybody. So this is, I think this is a cool picture. So this is from the Stone group at Indianapolis, and this is to show the pictures of the Randalls Plaque with extension into the tubules. So the initial lesion that is seen with idiopathic hypercalciurics is the deposition of calcium and phosphate on the antiluminal side of the loop of Henle. So if you think about the loops of Henle, the ones that are deep, that go all the way down into the papilla, these guys deposit calcium phosphate on the antiluminal side, so the basolateral side, literally right next to the collecting system. So what happens is, and it's probably better seen here, is that basically you have this plaque underneath, and then the crystal material starts to erode through. And then as it starts to erode through, and I guess it kind of roughens up that surface there, then you get calcium oxalate stones depositing on that eroded surface. So for some people who have like an enormously huge stone burden, one of the treatments is to have the urologist go in, which is what you see here. They will look at the collecting system there, and they will literally pluck off these stones. So you can see here, this is a whole cluster of baby stones, because it's highly magnified, baby stones on top of this collecting system, and then after they take it off, you can see these whitish, plaquish areas that are the plaque that is formed. The plaques are pretty interesting looking, and here are some of the EM pictures of what they look like. I have to say, nobody really knows exactly why this happens, but it's really, really common. And another nice little stone. This one was pulled off of somebody had surgery on their collecting system before, and you see this little groove there. That was a stitch, so it formed on a stitch. Okay, so case 5 is a 29-year-old Caucasian woman who's referred for nephrolithiasis. She had a history of obesity and bariatric surgery. Her exam was notable for overweight status, and she'd had multiple abdominal scars, and her CT showed bilateral, non-obstructing stones. So here is her lab work, and you'll notice the features that are of importance. Her bicarbonate is low, which is frequently the case in somebody who's had significant bariatric surgery and has chronic GI losses. Calcium is low, albumin is low as well. Her urinalysis is remarkable for a relatively low urine pH of 5. Remember that the lowest that your urine pH can get to is about 4.7. And she's got a urinary anion gap of minus 25. So this woman has metabolic acidosis, but she does not have distal renal tubular acidosis. Her urinary anion gap is negative. So in fact, she is putting ammonium into her urine, the normal response to a metabolic acidosis. PTH is midline. Rest of her electrolytes are okay. And the notable things here, from a stone person standpoint, are that her 24-hour urine volume is 700 mLs, so this is a relatively low urine volume. Calcium is not hugely high. Oxalate is fairly high at 53. Citrate is very, very low, remembering that for a woman you're looking at a normal of 450 to 500. This is probably a consequence of her metabolic acidosis. And her uric acid is actually pretty high as well. So she's got calcium nephrolithiasis with a relatively normal PTH in 125. She's got mild hyperoxaluria, severe hypocitraturia, metabolic acidosis with a normal anion gap due to gastrointestinal fluid losses. So this woman had calcium oxalate stones due to enteric hyperoxaluria and her hypocitraturia as well. So her major risk factors were certainly her very low urine volume, her hypocitraturia, and her hyperoxaluria. Also, interestingly enough, these individuals, although they can get enteric hyperoxaluria and therefore develop calcium oxalate stones, because they frequently have a very low urine volume and a very low urine pH, they are also at risk for uric acid stones as well. So the current dogma as to why people develop enteric hyperoxaluria and how this works is that we think that oxalate generally complexes with calcium in the gut. However, with fat malabsorption, you get calcium that is complexing with bile acids, and this then leaves the oxalate kind of free, and so it's easier to absorb it. However, more recent studies have suggested that all the time in the gut, in the small intestine, there's oxalate going back and forth. So you've got some absorption, you've got some secretion, and it would appear, at least in some of the animal models that have been studied, that absorption of oxalate is really not that dietary dependent, and is fairly fixed. That the real contributor to oxalate metabolism in the gut is oxalate secretion. And so here is where the notion that your intestinal flora are very important for the prevention of stones comes in, and particularly in the setting of enteric hyperoxaluria. Because there's a whole slew of bacteria in your gut that eat oxalate. They love oxalate. That's what they subsist on. And when you have those bacteria, then your gut continues to secrete oxalate into the lumen. These bacteria eat it up. They love it. There's more room for more oxalate secretion. So there's like this constant sink. If you lose those bacteria, then the ability of those transporters to transport oxalate into the gut lumen will be diminished. So you've got good bacteria chewing up oxalate. You got bad bacteria that don't chew up the oxalate and therefore limit the amount of oxalate that can be secreted. So our current options for treating hyperoxaluria are to give people calcium supplements, the calcium hopefully then binding the oxalate so that it doesn't get absorbed, and to eat a low oxalate diet. The newer ideas are to do things to help your gut secrete oxalate. So, in fact, there are trials going on with feeding people Oxalobacter formigenes, which is one of those bacteria that eats oxalate. This is probably pretty much like many of the other trials going on now where they're trying to use probiotics, and that is to say that, you know, it's something that you have to do all the time. You can't just like repopulate your gut and then they're there forever. You seem to have to do it over and over again. Some pharmaceutical companies are also looking at developing an enzyme that'll cleave oxalate, you know, such that you take this enzyme, the oxalate gets cleaved, and therefore you have more room to secrete oxalate. So here is a really nice dramatic picture of nephrocalcinosis. This is what nephrocalcinosis looks like on a KUB. This is not an IVP or anything. So you can see all of those calcium deposits all the way through basically the medullary portion of the kidney. So I'll conclude in saying that stones may be a presenting feature of many systemic diseases. You know, we've talked about a few of them that I have diagnosed, you know, purely on the basis of the fact that just looking for stones. Hyperparathyroidism, Sjogren syndrome, sarcoidosis. You know, ones that I haven't mentioned, I've diagnosed lymphoma with somebody who had hyperuricalciuria due to rapid cell turnover and had developed uric acid stones for the first time in his life when he was about 70 years old. There are many, many diseases that are accompanied by stones. And a metabolic evaluation can really lead to therapies that result either in the limitation of stone formation or in some fortunate cases like hyperparathyroidism, just the complete cessation of stone formation. And with that, I will quit. I'll be happy to take any questions. Okay.